So now you are all on record. Smile, I'll make you famous. Bring this up. Okay. We're going to stick to the lower part of the genitourinary system. And we're going to address some more elimination. Only this time we're going to talk about benign prostate hyperplasia. Say that fast 3 times. And urinary retention and urinary incontinence. Now, some of this may sound a bit repetitive because we talked about cystitis, which could cause urinary retention. Urinary incontinence and urinary retention are more symptoms than they are actual diseases. But being nurses in the hospital and the care facilities, we're going to be dealing a lot with those 2 symptoms. So I just want to address them in general. And it kind of helps when you'll find that in your nursing diagnoses. Your nursing diagnoses will not be benign prostatic hyperplasia. You're going to be dealing with the person who has BPH, and he will probably have urinary retention. So urinary retention, thus, will be your nursing diagnosis. Remember, we can't do medical diagnoses. We can only do nursing diagnoses. We do that just to confuse you. Remember, if you see this guy, you may see it again on the test. He's my buddy, and today we're going to talk about the case of the missing P. And it's tobacco. I want to point that out. So moving on. We have elimination. What is elimination? It's the secretion and excretion of body waste. This is the same thing that I pointed out in the previous lecture. So nothing new. I'm going to change my pen color so that I can draw circles around things. That's so much fun. Here we go. Moving on. There again, the urinary tract, we can pretty much break up into the upper urinary tract and the lower urinary tract. Now, I know in the last session we talked about kidney stones, which include the ureters. And the ureters can be the upper part of the urinary tract, or they can be the lower. It's just a matter of opinion. For our purposes, the ureters are part of the upper urinary tract. And the bladder and the urethra is part of the lower urinary tract. There again, same slide as last time, KUB, kidneys, ureters, and bladders. If we do a KUB x-ray, we're x-raying this part of the body right here. Moving on. What is urinary incontinence? Urinary incontinence is the inability to control the voiding of urine. Unlike urinary retention, which is where you can't void at all. So in other words, an easy way to remember this, urinary incontinence, these are the people that pee the bed. That's just an easy way to remember it. Incontinent means you can't control it and you pee the bed. We deal a lot with this because a lot of our patients are in a unconscious or semi-conscious condition, so they can't control their voiding. Or they may be old and they've just lost the ability to control that. Let me see if it involves, okay, I don't know if I'll talk about it here, but about 1/3 of older adults suffer from incontinence. There are 2 sphincters that go from your bladder to your ureter. You have the internal sphincter and you have the external sphincter. Now, they're both closed until your bladder fills up to a certain point. when your bladder fills to a certain point, somewhere between around 300 to 500 milliliters, the internal sphincter reflexively opens. And this allows the urine to go down to the external sphincter. Now, when that happens, that's when you go, oh, I gotta pee. Now, you don't have any control over the internal sphincter. It does that automatically. But the external sphincter, you do. This is a sphincter that we've conditioned. When we were born, we couldn't control it. And then as we gained control over it as we got older, you learned to keep that external sphincter closed. That's when you're holding your bladder, keeping yourself from peeing. And we even learn to control it unconsciously so that we don't pee the bed at night. So it's a conditioning, but this is a voluntary muscle. This is the one we actually control. So you're going down the road and you drank your big gulp 7-Up and your bladder's full, your external sphincter opens up and the urine hits the external sphincter. The internal sphincter opens up and hits the external sphincter. Boom, I gotta pee. And now you're holding it because you gotta wait until you get to a restroom. Once you get to a restroom, then you consciously let go and your external sphincter opens up and it goes out. Now, the problem with older adults is they begin to lose the tonal, not the word I'm looking for, but they start to lose control of that external sphincter. They lose the muscle tone. They lose muscle tone in the external sphincter, so they can't control it as well, and they end up leaking a lot, which is why you'll see a lot of older adults wearing incontinence, Depends, incontinence shorts. Trying to find a political way of putting it. So there's several things that can cause a person to be incontinent. In the older adults, that is losing the muscle tone on the external sphincter, which is a primary cause. But there can be other things too, infections, a variety of different things that can cause you to have incontinence. Any questions on that from anybody? You'll be dealing a lot with this in your care. Assessment's pretty simple. They're unable to control their urination. So I mean, it's pretty obvious when that happens. Diagnostics, what we want to do is we want to look for any physical causes of why they may be losing continence of their bladder. Blood, WBCs, things like bladder infections can cause a degree of loss of urinary control. I will point out here, I didn't point out in the last slide, but just for your information, if you get a bladder infection in an older individual, especially in a care facility, they can literally go bonkers. Psychologically, they go off the wall. So if you're working in a care facility and you have an 80 or 90-year-old patient, and then suddenly that patient's getting angry, violent, seeing lizards on the wall, whatever, and you're wondering what the heck is going on with this patient, because it's kind of a sudden onset, first thing I would look at is get a UA and see if they have a bladder infection, because the bladder infection will drive those older people nuts. So just a little piece of trivia to stick in the back of your mind. There again, if there's a serious problem with bladder incontinence, they may want to do a uroscopic examination and see what's causing it. And there again, that's the same little picture we had before. Medical management, the key is determining the cause. If it's just loss of tone of the sphincter, there are some medications that we can use for that. The different things that can cause incontinence, they can have spasms. If they have bladder spasms, you know, the bladder will push and they won't be able to catch it. So they have an accident and they urinate. Oxybutinin is one medication that reduces the spasms on that bladder. Sphincter control, urocholine can be given to individuals who've lost some of that muscle tone. Benign prostate hyperplasia might be a problem, and we're going to address that further on, so I won't talk about that right now. And bladder contractions, that's a desire to push. Anticholinergics seem to help reduce that. So there's just a couple of medications that the urologist would probably prescribe for somebody who has urinary incontinence. And surgery. I don't know, I'm not aware of any artificial means of improving the external sphincter's function, but if there's something that is up in there, like you use surgery for BPH or whatever, it might fix the problem. How we can help, especially with the older patients that are losing their control of the external sphincter, Kegel exercises. Any of you who have, I think, ever been pregnant or given birth, you may be familiar with the Kegel exercises. I think you utilize those as a part of the pregnancy. I'm not real sure. OB is not my strong point, but that's just where you're contracting your rectum and relaxing or the area down below. It's just like when you're traveling across country, oh God, I got to go to the bathroom, and you tighten up real tight down below to keep yourself from having an accident. That is a Kegel exercise. Barrier garments, there again, adult pants. These are the Depends. Condom caths, they are like a condom, but they have a hole in the end to which you attach a tube and a bag. It's like the catheter, only it's nice because it's not invasive. You're not putting anything in the ureter. What you're doing is you're just putting on a condom that's got a little tube on the end that goes to a bag so that they are able to go without soiling their garments. The bad thing about incontinence is urine, or the urea is almost acidic to the skin. And if people lay in their urine, it breaks down the skin tissue rather quickly, which is why if you have a patient who is incontinent, you have to do something about it. If they lay in their urine, the tissue on their backside is going to break down. You're going to have a bed sore. You're going to have a real problem. So incontinence is a serious issue. And there again, impaired skin integrity. There is a nursing diagnosis right there for anyone who's incontinent. You're trying to protect the skin by whatever means you can, whether it's a garment, putting on skin barrier creams. Next week in lab, we're going to be talking about bed sores, and I'll go over a lot more of that as to how to prevent bed sores. But the best thing to do is if we can direct the urine to where we want the urine. The second best thing is putting up a barrier in case they're incontinent so that it doesn't impact the skin. And psychosocial issues, when somebody has trouble with this, it can work with their head. You know, I'm getting old. I have to wear adult pants now. There's some psychological issues there. You have to assure them that this is perfectly normal. You know, it's okay. You know, be psychologically reassuring to the patient. It's not fun. Flipping over to urinary retention, this is just the opposite of urinary incontinence. It's the inability to urinate. You can't urinate. There's two different types. There's the acute. This is usually temporary, and this is caused usually anesthesia can cause urinary retention. So if somebody had gone into surgery and they come out of surgery, they're having trouble urinating, it was probably the anesthesia. And there's certain drugs also that can cause urinary retention. The good thing about this is when the drugs wear off, they go back to normal. The one that we're usually more concerned about is the chronic urinary retention. BPH is the most common. Your prostate swells up and you just can't pee. And we'll talk about that in the next section. And neurogenics. There again, some of those neurogenics can be caused by drugs as well. But neurologically, your sphincters clamp down and you just can't get it to open up, whether it's the external or the internal. And mostly what I've seen, it's been drugs that cause that. I can't off the top of my head tell you which ones. Assessment. Acute urinary system. One thing I wanted to mention about the neurogenic. This can also be head injury, any neurological problem. If they have a head injury can cause a variety of things. It can cause incontinence, it can cause retention, and it can also cause priapism. So any of those kind of neurological problems, especially lower on the spine, you can have trouble. I know a lot of the paraplegic. I worked for a quadriplegic at one time, and we had to use a urinary catheter because he did not have the ability, being paralyzed, he did not have the ability to relax that sphincter. So there's another example of neurogenic urinary retention. What it will cause, you'll get a distended bladder, a sense of urgency, and as that bladder expands, it will cause lower abdominal pain. I mean, we've all been through it on that long trip across country. You get into Montana and there's not a bathroom to be seen for 500 miles. There again, if you're doing a tympanic assessment, you're tapping on their bladder like that. Also, we'll talk about this later, but using a bladder scan. Bladder scan is a tool that they have on the unit, and I think almost all units have them nowadays. It's basically just a small device that you can actually scan the bladder, and it will tell you exactly how much fluid is in that bladder. If this individual is getting above 300 to 500 cc's of fluid, they are probably retaining urine, and they will probably need a catheterization to empty that bladder. For chronic problems with urinary retention, you can wind up with an overstretched bladder that reduces the muscular tone of the bladder. They call it nurse's bladder because nurses are notorious for being so busy they don't have time to go to the bathroom. So that's how they got the name nurse's bladder. But that can cause problems because then the bladder is unable to void completely. And if you get urine remaining in the bladder, wherever urine sits, you can get a bacterial infection. So getting an overstretched bladder can increase your chances of getting UTIs. Unable to contract properly. Yeah, okay, this is basically what I just said. The bladder will be unable to contract properly, thus you don't void the bladder completely, causing urinary retention. Not urinary retention, but residual urine in the bladder is how you term it. Any questions on any of that so far? Good. Here is the bladder scan that I was talking about. They come in a variety of shapes and sizes. But basically what you will do is here you have that gel. If you've ever had an ultrasound done, and there again, those of you who had babies and went in and had an ultrasound on your belly, they put that real cold jelly all over your belly, makes you jump through the roof. You will put that on the person's lower abdomen, and then you take this scanner here and you float it over the top of the belly. And you will actually get a numerical reading on the bladder scanner that tells you how many milliliters of urine are in that bladder. It's really a cool device. I love playing with those. They're portable. You do it at the bedside. And it's done on the floor. They don't have to go down to your radiology or anything like that. You will be doing this as a nurse. And it's really cool. There again, if you're over 100 milliliters, I wouldn't really worry too much at 100 milliliters. But when you start to get up around 300 and 400, and they're not voiding, you may have to call the doctor and say, hey doc, I did a bladder scan. There's 400 cc's of urine in there. They're complaining of discomfort. What would you like me to do? Do you want me to do a catheterization? And there's a variety of different catheterizations you can do. There's the indwelling, which you guys practiced in lab yesterday and Monday. And then there's also the straight in and out cath, which you just put the catheter in, they pee, you pull it back out again. So there's several ways of fixing that problem. You might want to remember the bladder scan. Other things you can do, there's urinalysis to find out what may be causing the urinary retention, and a couple different tests, which I won't go into a whole lot of that. But if you're curious, those are some of the tests you can look up if you wish. I will not test you on any of those. Management. Now, again, this is what the doctor would be doing. Dilation, remember I showed you the bougies. The bougies can dilate and hopefully dilate that external sphincter enough that they can actually pee. If they're, you might want to use that if there's scar tissue, if there's a spasm, something like that. What we'll be doing is we'll be putting in a catheter, either an in and out catheter or an indwelling catheter to help them urinate. And there's urethral stents. So the same way you could put a stent up in the ureters, you can also put a stent in the urethra. That'd probably be if there's a lot of scar tissue. On the chronic, okay, IUC. That means indwelling urinary catheter. That's a fancy term for what you guys did Monday and Tuesday in the lab. Indwelling urinary catheter. Can be done by the patient. Okay, I think I might have messed up on the slide here. Normally, the patient will do an in and out cath, where they put the catheter in, they pee, and they pull it back out again. The indwelling catheters are what we do. So I'll have to go back and look at that. I think I might have messed up and got those two mixed up in that slide. But anyway, there's two different types of catheters, the indwelling and the in and out. Suprapubic cystostomy, that is like a colostomy, only it's a colostomy for the bladder. They actually go, do I have a picture of that? Yeah, I do. Okay. They actually poke a tube into your bladder, which then drains into a bag, just like an indwelling catheter. Now that is that there's something really bad going on down here. Maybe prostate cancer or testicular cancer, anything going on down here where they just don't want the urine. The normal flow of urine would go through here like this. We can't use any of this plumbing here, so we have to actually put a ostomy in their bladder and drain it directly into a bag. Things are getting bad when you have to do that. Okay, here we go. Here is a straight cath. You always know a straight cath because a straight cath has just one opening. We insert this in the urethra, they pee into the toilet or into a container or a bedside commode or whatever. And then when they're done peeing, they pull it back out again. We normally just call it an in and out cath. Here is the indwelling catheter, which you guys worked with this week. And you'll have two openings. You'll have one where the urine comes out, and then you have the balloon. And that's what's used to blow up the balloon. So there's also a third catheter that has three openings, and I'll talk about that here in just a moment. Management, medications, analgesics, antibiotics, if whatever's going on as a result of an infection, catheter instruction and care. If they're doing an in and out catheter, you may be responsible for instructing them on how to do that. It is not a sterile procedure, but it's aseptic. They have to be very clean. If they're not clean, they stand the chance of causing a urinary tract infection. So be sure that if you have to instruct them in an in and out cath before they go home, be sure you bone up on your instructions real well before you instruct them. And post-surgical management if they went in to have any kind of surgical procedure done. Any questions on that before I move on? Everybody still awake? Everybody got their coffee?
I have one question.
Sure.
For a straight cat, a female can do that too?
Yes. Yeah. Are you talking in and out catheter?
Yeah, in and out catheter.
Yes.
Okay.
As you probably saw from the lab, it's more difficult on the female.
Yeah, that's why I'm just asking. Like
self-cathing on the female is probably easier than us doing it because they're a little better at insertion. But unfortunately, with the female, there's an increased risk of infection because of it's a very moist area, and there's a lot of chance so they have to clean very, very well. If you're going to give instructions on the female, you really have to emphasize cleaning the area real well. Okay. The last, but definitely not least, is benign prostate hyperplasia. What does that all mean? Well, benign For those of you who've been around the cancer world, there's benign and malignant. Malignant is bad, benign is good. Benign means it's not cancerous. A lot of males get prostatic hyperplasia, and they will test to make sure that it's not cancer. If it's not cancer, then it's benign. Prostatic just means it's a prostate. There again, the prostate is a walnut-sized gland that surrounds the ureter, and it's responsible for secreting certain fluids during sexual intercourse. Hyperplasia just means it's an increase in cell production. So in other words, it grows. It's not cancerous, but it grows and it swells. Now, there's a lot of medications out there to help reduce that swelling. So, but I'll get more into that as we get to the medical treatment. Common in men, 50 years and older. So might see that again. It will not happen in women. Women do not have a prostate. Usually not a problem. I mean, some men can just get some mild swelling of the prostate and it's not a big deal, but when it starts clamping down on the urethra and you can't pee, then it becomes a problem. And that's when they have to do something about it. Ta-da! Assessment. Slow and gradual reduction in urine output. When the prostate begins to swell, it does it very, very slowly. The men may not be able to void as much, but they might be voiding more often because it's harder to get the urine out. So they'll be getting up a lot of times during the night, a lot of nocturia, nocturnal urination. Oh, there we go. Frequent nocturia. This means you're getting up, 4 or 5 times a night to go pee. It's because you're not voiding your bladder completely and it fills up faster. Incomplete voiding, basically what I just said, they're not voiding it completely. Diagnostics, digital exam. This is the old-fashioned, you go to the doctor and he sticks a finger up your butt. This is the exam that all guys fear. What he is doing, and if you look in the back of the classroom, the senior classroom, there is a little plate that has 3 different size plastic prostates. And that we wouldn't really use that because we don't do that exam, but you'd probably find that in a medical school somewhere because it teaches the doctor what is a normal size prostate. And as it gets large, what am I feeling for if it's larger? But what they're doing is they're basically going into the rectum and they feel the prostate right here and they see how large it is. And that gives them a clue as to whether or not the prostate is swelling. As you can see, this is all prostate right here and it surrounds the ureter right there. Fortunately, we don't have to do that as much these days because we have wonderful blood test called a PSA. The PSA is a numerical value. I think normal is like 0.5 to 1 or 1.5. If you get above that, it's an indication that your prostate is swelling. Don't hold me on that, but I think that normal is 0.5 to 1.5, but I'm not sure. Don't quote me on that. But it's a lot easier to get a blood test. And they usually just throw that in with all the other blood tests you get when you go to see your doctor, your CMP, your CBC, all that. If you're a male, especially if you're over 50, they'll just automatically throw a PSA in there. And thank goodness now they have the stool sample too for colon cancer for male and female. So now they don't have to go in and do a colonoscopy on you anymore. They just test your stool and they use that as an indicator for whether or not you may be susceptible to colon cancer. So that's a nice thing. Alpha-renergic blockers. This is the medication that can help reduce the swelling of the prostate. Androgen hormone inhibitors. Androgen hormone, testosterone, the male hormone, testosterone. high levels of testosterone can cause the prostate to swell. Now, it's a double-edged sword because you start reducing a male's testosterone levels, it reduces their energy, it reduces their sex drive, it reduces their capacity to maintain muscle size. So it's kind of a two-edged sword there. That is not the preferred method of reducing prostate. And over-the-counter methods, saw palmetto is a natural herb that a lot of urologists will say, yeah, it does kind of help keep the prostate down. I don't know what medical evidence we have of that, but it was mentioned in the textbook, so there must be some evidentiary evidence of it. Otherwise, they wouldn't be putting it in the textbook if it was just a myth. But this is just a natural herb you can buy at Walmart or anywhere else, and it's supposed to help keep the swelling of your prostate down. I think it helps with baldness too. I'm not sure. Now, if none of those work and it keeps swelling, we may have to go to a TURP, transurethral resective prostatectomy. Say that fast 3 times. The TURP, there are different ways of going about it. So there are different terminologies, the TUIP, the TULIP, the tuna. These are all different methods of doing the same thing. I kind of joke around and I call basically a TURP is a roto-rooter. Just like a sewer system, you go in and you basically just cut tissue out to widen that hole and to allow the person to urinate again. It's not comfortable, and post-surgically, it's very uncomfortable for the males. They basically put this rod in here, they use a cutting device, and they just cut this tissue away to widen the hole. And I'm going to talk a little more about that. You may wind up with TURP patients. Now here again, I'm going to tell you about the third catheter, you may say. This is an irrigation catheter right here. This blows up the balloon. This is where the urine comes out. And this third one is where we irrigate the bladder. Now, unfortunately, here's a look at the inside of it right here. When we cut out that tissue in the prostate, we're literally cutting tissue. There's going to be a lot of bleeding. There's going to be a lot of clots. It's going to be messy. It's going to be dirty. All that blood and all those clots go into the person's bladder. So what we do is we have these huge bags. They're usually 3-liter bags. They're not like your regular IV bags. They're big. You'll recognize them, and they'll be a CBI. And what you're going to do here, it's called continuous bladder irrigation. Go away. There we go. Or CBI, continuous bladder irrigation. We're putting a regular catheter in there. We blow up the balloon right there. We got an exit for the urine, but we have a third one here where we're pouring this fluid, this normal saline, into the bladder to irrigate the bladder and hopefully wash all that blood and all those clots out into the bag. So you're going to be keeping an eye on this right here. Why this is very important for us nurses, we are going to be taking care of these patients, and we're going to see blood, clots, and crap in here. And what we want to do is we want to keep this CBI going until that urine starts coming out clear. Once this starts coming out clear, they're out of the woods. Until then, you have a lot of blood coming out. You may have clots, and the clots are what cause a problem. Because if you get a clot stuck in the tube right here, the urine stops, and their bladder is going to start blowing up because we're pouring a bunch of fluid into that bladder. So you need to keep an eye on how much fluid is going in and how much fluid is coming out. If you're pouring a liter of fluid into this guy's bladder and you're getting 10 cc's out in the bag, guess where that other liter of fluid is? It's right here in the bladder. So how much is going in and how much is coming out is a priority for you as a nurse. You have to make sure that keeps flowing. Now, I have done unclotting of these. If it does clot up, what you do is you stop this and you You turn it off. You pull this tube out and you get a syringe, one of those big syringes like you use for tube feeds, and you stick it in here and you just start pumping until you unclot this tube. Once you get that tube unclotted, you hook it back up to the bag again, and then things will start flowing again. So you may be responsible for unclotting that CBI. Very important. We don't want to pour 1 or 2 liters of, stop that. We don't want to pour 1 or 2 liters of fluid into this guy's bladder and not give it a way out. That can be dangerous. So always have the next IV bag ready. You don't want that irrigation to go dry. So you always have a second bag ready to go. Check the flow frequently. Also check and make sure that the tube coming out is not kinked, and blockages, that will be blood clots. You may have to clear those blood clots. So, check what's going in and what's coming out. Keep a close eye on that. Very, very important. And yeah, measure and compare the amounts. There will be a chart there. You'll be keeping track of it. So that's the important thing to remember. If you're doing CBI, make sure everything is flowing. Also look at the color and debris. You're going to be documenting this. At the beginning, it's going to be bloody, nasty, lots of clots, and those are going to clear up as the irrigation continues. Now the cartwheel. Post-surgical. Well, what nursing diagnosis might we have on a benign prostate hyperplasia patient? If they're post-surgical, if they had a TURP, there is a risk of urinary retention. But there again, if they're having CBI, that there may be the blockages, which I just told you about. If they're off of the CBI now, they may still get some clotting or some problems. So you still have to keep an eye. We removed the CBI now. He's not on that anymore, but he is a post-TURP patient. You still want to make sure if he starts to get urinary retention, something has gone wrong. You need to tell the doctor. It may be something as simple as just putting a cath in him real quick until things go back to normal. Or maybe the operation was not a success and they have to do something else. So keep an eye on that. Pain, this is painful. We're cutting that guy's prostate out inside and they do feel it and it is painful. So you are going to be doing a lot of analgesics with these patients. And risk of infection. Anytime you cut somebody open, you risk infection. Now, not only are we cutting open this person's prostate, but what normally goes by that prostate? Urine. Is urine clean? Not always. So if he has any bacteria hanging out in his urine, it can go into the site of the operation and it could go systemic. Got to keep a close eye on that. There again, if he has an infection, if you look at the urine, make sure the urine doesn't get cloudy, yucky, foul smelling. Blood's going to be normal. But if you see anything else, fever, chills, nausea, any of that that indicates infection, call the doctor right away because we need to jump this guy on antibiotics real quick. That is benign prostate hyperplasia. Any questions on that?
Is asparagus served a lot in hospitals, out of curiosity?
Is what?
Asparagus.
Asparagus. I have not seen it served at all. Why do you say that?
Oh, because because it makes your pee smell weird. And I was like, that I could see that happening in a long term, or it's like,
yeah,
oh God, it smells weird, and the nurse smells it and doesn't realize it's asparagus, and
that's a good
go
point.
down a wild.
Yeah.
I'm just kind of curious. You ever do you remember seeing asparagus and then that issue comes up that someone ate asparagus? Because I eat asparagus and I'm like, that smells really weird. What the heck is it? Oh, I had asparagus.
I've not seen a lot of that. There's also beets.
Okay,
Somebody eats a lot of beets. You can get some red tone in your urine, and you might think they got blood in their urine when they don't. Vitamin C turns your urine bright yellow. Somebody might think their patient's dehydrated if they're taking vitamin C supplements. So that's a good point. I mean, yeah, if you do see something unusual in the urine, diet may be something to look at, especially in a long care facility. If everybody ate asparagus, then suddenly everybody's urine is foul smelling. That might be a good clue. Play detective. Good point, Trevor. Anyone else?
I am going to